stress. It will be presented by our very hard-working and very intelligent DNB student, Dr. Shubham Saini. And the moderator for this is a very well-known pediatric pulmonologist, allergist, and sleep specialist. And she is head of Asthma Allergy TB Chest Center at Gurgaon and consultant for Marengo Asia, Gurugram. She has done the fellowship in pediatric pulmonology from All India Institute of Medical Sciences, and she is fellow of European Diplomat of Pediatric Respiratory Medicine, and she has done a diploma in pediatric sleep medicine also. She is having lots of awards to her name, and she is teacher and tutor for many of the courses which are run by Indian Academy of Pediatrics. She has written many chapters in many books on pediatric pulmonology, in addition to conducting this research and systemic review publications. So welcome, Dr. Jasmeet. She is part of our own Gangaram family. She has done the fellowship and DNB Pediatrics from our own department, and now she is her professional career at this site. And now she will be. Thank you, Dr. Jasmeet, for joining us. So, Dr. Shubham, can we start?
Thank you, sir. Yeah.
Yes, very
Thank
good
you
evening,
for the
sir.
warm welcome. I would appreciate.
Shall we start, sir?
हाँ, शुभम स्टार्ट कर दो. 8-5 हो गया.
Okay. Thank you, sir. A very good evening
Dr. Smith,
to
कर
you,
दें
ma'am.
start?
Yes.
ठीक. Start
Yes,
करो.
yes. If all the participants, we can start. No issues.
A very good evening, ma'am. Myself, Dr. Shubham, second year DNB resident. Today, I'll be presenting a clinical case with a case highlight as approach to persistent respiratory distress, ma'am. Now, starting the child named XYZ, who is a 22 months old male. He is a resident of Hathras, Uttar Pradesh. History is given by mother, who seems to be a reliable source. And the child was admitted on 23rd of the July 2026 in Gangaram Hospital with following complaints. Now, the chief complaints of my patient was the fever, which was 7 months back for 3 days. It was associated breathing, which was 7 months back again at the similar time for 7 days, and following that for the last 6 months. 7 months back, when he developed fever for 3 days. It was not associated with rigors. It was relieved on oral active looking interfebrile period. Now the fever was associated with cough, which was since 7 days. Again, it was for 7 months back only. It was gradually in onset, non-paroxysmal, non-productive, no diurnal variation, no postural variation, and associated with runny nose, fast and noisy breathing with chest retractions, which was also gradually progressive. Now, for the above mentioned complaint, the child was consulted with a local medical practitioner on OPD basis on the 4th day of illness. So some oral antibiotics were prescribed, but the fever persisted along with drowsiness and decreased oral acceptance. So the child was brought to the Agra, where he was admitted and treated as a case of pneumonia. Now the child was on oxygen support with nasal prongs and IV medications were given. The nature is not known. Now again, after febrile, after 3 days of treatment, but the oxygen demand persisted as child started having fast breathing and desaturations on room air. So the oxygen support was continued for a while. Now again, the parents took Lama and brought their child to other private setup, where again he was treated for pneumonia with supplemental oxygen only, with prongs 2 liters per minute and IV medication. Child was from oxygen, remained off oxygen for 7 days, which was all it was all happening in an inpatient basis. And after which the child started having fast breathing again, for which the child was put on oxygen support. Now again, since then, the child had persistent, fast, noisy breathing with oxygen demand, which was partially responsive to the nebulizations, with difficulty to, from Sir Gangaram Hospital in January 2026, where further on invasive mechanical ventilation for around 2 weeks. Then, since then, the child is on continuous oxygen support by nasal prongs with a range of 1 to 2 liters per minute in view of persistent breathlessness and has persistent whistling sound, which is not improving after nebulizations. Shall I continue, ma'am? Ma'am, shall I continue? Am I audible?
Dr. Smith, are you there? डॉक्टर स्मिथ है डॉक्टर स्मिथ मैं फोन करता हूँ डॉक्टर स्मिथ को
Yes.
Can you hear me?
हाँ डॉक्टर स्मिथ नाउ वी कैन हियर यू
Doctor,
आप अपना म्यूट मत करो अपना ऑन रख लो
ऑन ही है
ठीक है
Doctor, can you hear me? Hello?
Yes, ma'am, I can hear you.
So I was asking ki drowsiness, what do you mean by drowsiness of the child at day 4 of the problem when he
Yes,
was
ma'am, I can
brought
hear
to the
you.
hospital? So
Hello.
what do you mean by
Yes, ma'am,
that?
you're
What
audible.
do you mean by that? Was he conscious? Yeah. Just tell me about the detail of drowsiness, what you talked about the
Yes, ma'am.
child. You said
Drowsiness,
that
ma'am, like
drowsy tha.
the
Yeah.
activity level. Yes, ma'am. The usual activity of the child was decreased. Like he was not feeding well, and he was like there was eye-opening to verbal stimuli. Verbal stimuli, yes, ma'am. So
Yeah, we can say
normal activity levels
lethargic
were
instead
low.
of drowsy. Yeah, we can say lethargic instead of drowsy because drowsy will point out the conscious level and the CNS, which is not going towards the case as such. So probably the letharginess is important, like because of the respiratory fatigue and the distress, the child became lethargic, isn't it? That will be much better to say than the drowsiness part. So
Yes, ma'am.
you can hear me, na? Yeah.
Yes, ma'am.
One more thing you talked about noise breathing. I found it because we should not know the diagnosis right now. Right
Yes,
now,
ma'am.
what do you feel? Maybe the differential because 7 months back he had the problem. It was
Yes, ma'am.
persistent. In between, the child was taking off on and off.
Yes,
So,
ma'am.
like it was on sometimes at any point of time, the parents found that the child is okay, which is very important. Like no symptoms at all.
Yes, ma'am.
No
Actually, ma'am,
signs. Yeah,
the
it was.
history started. Yes, ma'am. Yes, ma'am. Actually, ma'am, the history started 7 months back. The child was pre-morbidly normal. Like he was a normal child with a normal activity level with the age matched peers. Since 7 months back, he developed a fever and febrile episode. It was associated with cough and respiratory symptoms, ma'am. So, from the history itself, it is very clear that it started with a respiratory pathology, ma'am, like a respiratory tract infection. It was.
It started with some infection, basically, which lead
Yes,
to
sir.
respiratory pathology. My question is that when he was taken to the hospital and received some course of treatment in the form of antibiotics, nebulizer, or whatever, and then he went back home. At any point of time in last 7 months, did the parent found the child totally okay? Like means no respiratory problem, no noisy breathing, feeding is okay. This much I want to ask. Is there any history that कि
Yes,
हाँ
ma'am.
मेरा
There
बिल्कुल
was.
ठीक हो गया था
Yes,
कुछ
ma'am.
दिन के लिए? There
Yes, ma'am.
was. So this is
There was
very
a period.
important because
Yes.
so what was that period? 10 days period, 11 days period, and again the child had some fever or not? That 7 months back he had fever. Then did he had the fever in between also intermittent
No.
or what
Yeah.
or he was okay and only respiratory
Yes,
was the
ma'am.
issue? The point is
Ma'am,
this.
the fever started. Now the presenting problem. The first chief complaint was
Yes,
fever,
that is
and it was
okay.
only for the yes, ma'am. It was for the first 3 days only. There was no again. No repeat episode of the fever. The child became afebrile on the day 4 of illness, and again he never had
Okay.
fever again. He
So
never had
in
fever again.
between
Yes.
in bet in between how many days was he was if how many days he did not have any symptoms? Have you asked this question to the
Yes,
mother?
ma'am. Initially,
Because
ma'am.
we
Yes,
know
ma'am.
everybody knows what is this. Yeah.
Initially, ma'am, first 3 days
Then,
there was
yeah.
fever, then there was cough, and after 7 days of the illness, the child was afebrile and he was off oxygen for like 7 days. When he was there in the hospital only on the inpatient basis, so the child was in hospital and he was afebrile and he didn't have any respiratory distress and he was off oxygen support for like 7 days. For after 7 days, he started having respiratory distress, tachypnea, fast breathing, breathlessness again. For which the child was put on oxygen support, supplemental oxygen support, ma'am.
Was the oxygen supplemental support given at home for the child or again in the hospital? Like,
Ma'am,
he required a
supplemental,
home oxygen?
yes, ma'am. Yes, ma'am, he required.
Like,
When the
I
child was brought to the hospital, there was a like, ma'am, he got on the day 7th of illness. He was afebrile and he was off oxygen. Then he remained off oxygen for 7 days. Then again he started having oxygen demand, and he was discharged to the like home. He was not discharged. The parents took Lama and brought the child to Sir Gangaram Hospital, and then he was on oxygen demand only. He was on oxygen support only, ma'am. After
वो
7 days
मैंने
of
घर पे
brief
ऑक्सीजन
7 days
लेता. My
of
question is,
afebrile period and brief 7 days.
right now the baby is 22 months. Right now the baby is 22 months. 7 months back he had the problem. In between that 7 months duration, he was going on and off
Ma'am,
with
actually,
the hospital
these symptoms
visits.
started
Was
in,
he? That is true.
yes,
My
ma'am, there were
question is, in
multiple hospital
between the
visits, like, ma'am,
7 month
there was
period,
three inpatient department.
that is what I want to ask. So there were multiple hospital visits. Every time he used to require oxygen supplemental, and I don't think so. This patient from Agra, वो घर पे उन्होंने home oxygen दिया होगा. Nobody must have told. They must have been getting, and there might be some period of hypoxia, मतलब which the
Yes,
parent
ma'am.
did not notice. Maybe that is the reason. या कभी इन्होंने बताया कि कौन से ऑक्सीजन कितना डिप हुआ हॉस्पिटल में, मतलब कुछ 1993 no oxygen
Yes.
requirements. Any history like this? It was not
Yes, ma'am.
there
Ma'am,
from the
initially, like, the
parents.
symptoms started in January. From like January to May, the child was on continuous oxygen support, ma'am. And the parents gave history that since last 2 months, his distress is like somewhat resolving, but he's on intermittent oxygen demand, ma'am. Intermittently, he develops tachypnea, and the parents have an oxygen concentrator at home, and they also
Got
monitor
it.
the
Got
pulse. Yes, ma'am. They also monitor the saturation with pulse
it.
oximeter, ma'am,
Did they
portable.
monitor the SPO? Did they monitor oxygen?
Ma'am,
How much was the
yes, ma'am.
oxygen? Doctor?
Ma'am, his
How much
baseline
was the drug?
SpO2 is like 92 to 94% on oxygen support.
Right.
When he's off oxygen support, the saturation dips to like 86 to 88%, ma'am.
Fine. Fine. Continue. Right. Okay. Yes. Fine.
Okay. Yes.
So you continue with the history. Yeah.
Yes, ma'am. I'm done with the history of presenting illness, ma'am. Now I'm starting negative history. Now, there is no history of intermittent episodes of wheezing, cough, and fast breathing, which is responsive to nebulizations. There is no history of foreign body ingestion, sudden onset of breathlessness. There is no history of suppressed cycle, excessive sweating over the forehead while feeding, recurrent pneumonias, or decreased activity level as compared to age-matched peers. There is no history of drooling of saliva, choking during feeds, and wet sounding cough or voice immediately post meal and tightness in limbs. There is no history of poor weight gain, delayed passage of meconium, passing greasy, bulky stools, chronic recurrent sinusitis, and poor weight and height gain premorbidly. And there is no history of tuberculosis contact and chronic fever. And there is no history of coughing up blood, child turning pale, and there is no history of exposure to bird droppings or any molds at home.
This is like very typical adult history we have taken. Very difficult to get child is having hemoptysis or something like that. Yes. What
Yes,
is the?
just try to
I think you will
comment.
come to the examination again. So what is the weight
Yes,
of the birth weight of the child? Any history of that? Birth weight of the
2.58
child
kgs, ma'am.
or the weight at 1 year of age?
1 year, ma'am,
And 1 year of
they
age पे
hadn't
कोई
they hadn't
कोई
documented at
आपको
1 year, ma'am.
weight बताया उन्होंने?
Birth weight was 2.58 kgs, ma'am.
7 months back कितना weight था?
7 months, ma'am, it was
Okay,
15
and
kgs,
7
ma'am.
months back जब admit हुए थे any whatever the weight?
15 kgs, ma'am.
15 kg weight means at the age of 15 months or 18 months, 15 kg is pretty good weight.
Yes, ma'am.
That
Pretty good,
means.
ma'am.
And after that, now you will tell about the anthropometry. So that will be, now I don't know how much is the weight, you will tell that. And
Yes, ma'am.
history of consanguinity. Are you coming to the birth history and the natal history,
Yes,
or
ma'am. I'll
like
come to the
what?
family history, ma'am.
Any
There was no
history?
history of consanguinity, ma'am.
Yeah. Okay, okay. So, why
No
am I asking this
history of
question to you?
consanguinity.
To rule out
Yes.
what? To rule out what? What do you think that what might be another differential diagnosis in this case by
Ma'am,
history
to rule
only?
out like, ma'am, by history only, it is very much
Persistent
clear that
problem.
there was a respiratory insult, which was, yes, ma'am. There was a respiratory insult initially, then which was followed by a persistent oxygen demand and persistent breathlessness. So the child must have landed into something like chronic lung disease after a initial respiratory insult. So I've kept my first difference
What type of chronic lung disease? What type of chronic lung disease you can
chronic lung disease
think
like
of
associated.
in this case?
Chronic lung disease can be differentiated like into airway related, ma'am. It could be at the alveolar level. It could be at the parenchymal level, like three
फिर भी कुछ
node.
बताओ क्या सोच सकते हो आप बच्चे का
Ma'am,
जो
post.
7 महीने
Yes,
15
ma'am.
महीने की एज पे शुरू हुआ
Post infectious,
and he
ma'am.
has a
Yes, ma'am.
persistent post infection is one thing, maybe because it may be a what type of infection do you feel? It's a viral, bacterial.
I
You
think,
said
ma'am, it was a
tuberculosis history.
tuberculosis less
It
likely, ma'am.
can
There was
be.
no chronic history. Viral
Yes,
pneumonia is
yes.
likely, ma'am.
तो वायरल में एक क्वेश्चन आपको और पूछना चाहिए कि क्या उस समय पे पेरेंट्स या फिर घर में किसी और को कफ कोल्ड था जब बच्चे को
Family
हुआ
history, yes,
because
ma'am.
that will go towards asking you viral maybe at during that time the viral was going on in the family or somebody has visited in the family who had some symptom infection and after few days or something the child also develops this. So one important question is that what is the family history during that time मतलब viral episode and what was like parents doing and like smoking history I think you will come to that. That is also very important to ask. Another like you told us already a negative history of no loose stool bulky stool, so मैं आपको थोड़ा hint दे रही हूँ what are you ruling out
Cystic
in that?
fibrosis, ma'am.
Yeah,
Cystic
very
fibrosis.
important. Why? Because sometime in 65, there is maybe I've seen many cases in All India Institute of Medical Sciences being a referral area. आप लोग भी यहाँ देखते होंगे. तो उसमें
Yes,
ये
ma'am.
होता है कि may not be a history of consanguinity.
Yes,
Only
ma'am.
the child we have to think कि yes may not be having a postnatal problem कि जरूरी नहीं कि meconium हो कुछ भी नहीं हो.
Yes, ma'am.
They might have little bit of gastric problem but may not be and 6 months के बाद उनकी problem शुरू होती by noisy breathing like they have some gargad wali आवाज which the parents come to it
That
and then
sounded
failure
wrong.
to
Yes,
thrive after some month and then very important to rule out cystic fibrosis. It is important. And post infections, we are already dealing with it. Cystic
yes, ma'am.
fibrosis. If the case of an interstitial lung disease comes to you, at what time the age the child presents? Can you tell me? Is it that 7, 15 months? Will they present the interstitial lung disease or it will be little later age group?
Ma'am, it will
So
be later.
ILD
Yes,
sometime rule
later.
right. Good. So ILD somehow the age group is not fitting into it.
Yes,
Cystic
ma'am.
fibrosis, yes, we can think of it, but we have to use specific tests to go for it. Post infectious, you very well said, but you have to ask the family history of viral infection in the family. Tuberculosis, still we cannot rule out, but still,
Yes,
yeah, we have to still go for the test for that. So you can go ahead for that. Yeah,
yes, ma'am.
yeah.
Yep.
Go ahead with the negatives. I mean the
Actually,
family history. Yeah.
yes, ma'am. I'm done with the negative history. Now, starting with the past history, there is no history of similar illness in the past in children, and there is no history of any previous hospitalizations also.
Yes, okay.
Now coming to the yes, ma'am. Now coming to the birth history, the child was born in Hathras in a private hospital. It was lower segment cesarean section in view of non-progression of labor. It was the mother was primigravida. It was the first order child, and period of gestation was 36 plus 4 weeks, and the baby cried immediately after birth, and the birth weight was 2.58 kgs. There is no history of neonatal respiratory distress and no history of any NICU admission.
Okay. Any abortion and nothing was there for the mother.
Nothing, ma'am. No
Primary.
abortions, ma'am. The primigravida, ma'am. No abortions,
Good.
ma'am.
Socioeconomic देखा पूछा आपने? Socioeconomic.
What,
I
ma'am?
mean very it's very basic but किस type के background से आए हैं which is very important and what the
They were
parents do and
lower
something like that.
socioeconomic status, ma'am.
Okay,
Basically,
okay.
yes.
Okay,
The father was
okay.
laborer, ma'am. Yes.
Fine.
Yes.
You talked about
Uh,
pigeon feather dropping 6
Yes,
What
ma'am.
do you think? Why did you ask such history?
I just wanted to like
Picture.
hypersensitivity, like deteriorating hypersensitivity
Pneumonitis, right, right.
pneumonitis. Yes, ma'am. So I asked.
Yeah, yeah. But that also develops a little later on the age of not at 15 months of the age. Very difficult to say. First, the child will develop some symptoms of any cough, cold, and all, but later on, they can still have this hypersensitivity pneumonitis. But take care, we can see such children, but later age group around 5 to 12 is a more commoner age group, but lower down also can be seen. Yes, fine. Pigeon feather grip. Okay, you can go
Yes,
further
ma'am.
with your anthropometry and examination.
Yes, ma'am. The developmental history was fine.
Dr. Suresh, fine, fine. Go ahead.
Yes, ma'am. And the child was immunized till 6 months of age. Now, coming to the family history, there is no history of similar complaints in the family members. There is no history of the atopy. There is no history of tuberculosis, and there is no history of any cardiac disorders, ma'am. Consanguinity, ma'am, I forgot to mention here, but yes, I did ask about the consanguinity, but there was no consanguinity, ma'am.
Mm. Okay. 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 Further, you can go ahead. Fine. So, in this history, what do you feel? What have we ruled out as such? There's no family history of any
Yes, ma'am.
atopy,
There is,
allergy,
yes, ma'am. There is. Yes,
and
there is no
the
history of any history.
child was not responsive to any nebulization. Can you any history of which type of nebulizer they were using? Very difficult.
They were
If
using
it's
Foracort,
like
ma'am. They
okay,
showed
doesn't
the
matter.
yes, they
And
showed the MDI.
acha,
Yes.
they use Foracort. Do you think Foracort should be given at so early age?
No, ma'am, it's
Have
not.
why they've
GINA
given
guidelines doesn't say it
not
can't be used.
recommended,
Not
right?
recommended. Yes, ma'am.
Yeah,
I
right,
think they were
right,
using it
right, right.
off label.
Because
Might be some local practitioner must have
off
given. I
label.
think.
Because why they wrote Foracort? Can you think from the perspective point of the doctors? Some why when we don't know about the pathology much, what
Yes.
mistake, what we think कि वो लिवुलिन से ब्यूटी से फोरोकॉट में गए मतलब what they must be thinking a difficult to treat asthma. That is why they went till forecourt, isn't it? So
Yes, ma'am. It
what
could
is this
be possible.
whatever we are coming to the diagnosis, what might be differential diagnosis means yes, a post-infectious illness.
Yes,
Maybe
ma'am.
we are dealing with an asthma which is resistant to other medications. So that is why they were upgrading it, and that was causing loss to the child. So
Yes,
once
ma'am.
we
Might be one
find that
reason.
the nebulizations like bronchodilators do not have good effect, then probably upgrading to the such thing should not
Yes,
happen.
ma'am.
So this is very important to give message, right?
Yes,
Good.
ma'am.
Yeah.
Actually, ma'am, I think we have since there was no history of any intermittent episodes of wheezing cough, so not a
Mm.
phenotype of asthma, but it's difficult to diagnose asthma at this age group. But again, the history was not in favor of asthma,
So
ma'am.
we can diagnose asthma after 1 year of the age. That
Yes, ma'am.
is not the issue. Basically, the what are the good criteria of asthma diagnosis is that there should be more than three episodes of wheezing or breathing difficulty or coughing, which are good responsive to bronchodilators. And
Yes, ma'am.
intermittent, the
Yes,
child
please.
becomes totally fine and do not require such. And that is why I was asking me, he was totally fine, but I think there was no history of total okay with
No,
the
ma'am,
child
he was
because
saying
he
there
was
was.
requiring repeated hospitalization.
Yes,
So
ma'am.
asthma can be diagnosed above 1 year of the age if the three criteria go into the picture, more than three episodes, and they are responding to the bronchodilators completely. But in this case, it is less likely to be asthma, not even the other type. So we should not upgrade the anti-asthma medication in spite of think of some other criteria, which maybe we are dealing with some post-infectious pneumonia or some illness like that, or which is not responding to. So
Yes,
one of
ma'am.
them is interstitial lung disease, one of them is cystic fibrosis. We will further go with it when the whole thing comes, like when you will examine and what do you think about it.
Yes, ma'am.
So and PIBO comes into the picture,
Yes,
post-infectious
ma'am. It
bronchitis.
comes
Now it comes to the picture because the child is not responding to this thing.
not
And at any
responding to
point
the
of time, did he
medication.
take any oral steroid or something ऐसा कुछ था उनके कोई केस में?
Ma'am, oral steroids it didn't take. Like when there was a inpatient admission in here in Gangaram, we gave like after suspecting that I'll tell later, ma'am. like
वो अब
Queen
आप
Ganga
बता रहे हो
replaced.
ना, which are next any other
Yes, ma'am.
history you think? अब आप examination पे आ जाओ, ठीक है,
Yes, ma'am. Coming
fine.
to summary, I'll summarize on the basis of history, ma'am, first.
Yeah, sunrise.
Now at 22 months old male, born of term lower cesarean section, developmental milestone achieved normally and immunized till 6 months of age. It was admitted in Sargangaram Hospital with complaints of fever, cough, and noisy breathing 7 months back. This was followed by chronic persistent breathlessness and oxygen demand for like 6 months. Now, from the history itself, my differential diagnosis would be chronic lung disease, ma'am. First, I would like to keep a differential of small airway related. It could be post-infectious bronchiolitis or recurrence. Secondly, there could be less likely, but then small airway. Then second could be large airway related, like a vascular sink, which is compressing on the like bronchus and causing a anatomical cause of bronchoconstriction. And parenchyma, like think of interstitial lung disease, less likely. And at last, of chronic pulmonary disease, alveolar causes like surfactant protein deficiencies and pulmonary alveolar proteinosis. Like the age is a little far away, but it could be one differential.
बहुत
Some
लंबा
cases.
cystic fibrosis बता सकते हो आप.
Yes, ma'am.
Cystic
Cystic.
fibrosis
Actually,
one of
ma'am.
the
Yes,
thing.
ma'am. We
Because
should rule out
pulmonary
cystic
alveolar
fibrosis.
is very, very rare. We should rule out cystic fibrosis, very important. Even these children can develop it at 5 years of the age. ऐसा कुछ नहीं है. But they just have subtle symptoms. They are mild variant of CF also, we can see. CF is
Yes,
also to
ma'am.
be kept in second or third, what I feel in the differential diagnosis. Yes, in the last you can PAP or surfactant, but again, they can also occur at 9 months or 10 months of the age. Okay, fine.
Yes, ma'am.
So we
Actually,
can come to
ma'am,
the examination part.
yes. Now, starting from the general physical examination, now starting from the vitals, ma'am. The pulse rate was 110 beats per minute. It was regular. The respiratory rate was 46 respirations per minute. The saturation was 98 initially at 2 liters, but we decreased it to 1. And by nasal prongs, and it was 90% on room air at the time when I examined the child. The temperature was 99 degrees Fahrenheit in exhala. The peripheral pulses were well fed, and the capillary fill time was normal. BP was again normal, 92/54, which lied in the 50 to 90 centile range. Now coming to the anthropometry, the weight of the child was 12 kgs, which was between 50 and 75th centile. It reduced like 3 kgs in the last 6 months, and height was 86 centimeters, and mid-param circumference was 12 centimeter.
That seems to be okay. So what is it? Stunted or what do you feel it is? Decrease the weight? What might be the thing?
There was again there is significant weight loss in the last 6 months, but I can't. But the percentiles are normal, so I can't say stunted.
Okay, fine. Because 86
Yes, ma'am.
centimeter height is pretty okay, which you said okay.
Yes, ma'am.
Only it is decreased weight which has occurred.
Yes,
So
ma'am. Weight
it
was decreased. Yes.
It shows that the problem started after 1 year of the age group or somewhere out after
Yes,
that.
ma'am. Yes,
Yeah.
ma'am. Initially, the child was thriving well, ma'am.
Thriving well, right.
Yes,
Right. So it rules out some PAP or congenital diseases too.
Yes, ma'am. They're less
Yeah,
likely. Usually, they
less
have
likely.
neonatal presentations, but
Yeah.
there are some case reports from. That's why
But
I added.
CF can still exist. Yeah.
CF, yes, ma'am. Actually, I took negative stage, so I thought I could have ruled out on the history,
एक
but
और
I
नेगेटिव
should
हिस्ट्री
keep
आप ले
it.
सकते थे पेरेंट्स से. एक और सोच के सकते. Sweat if the taste the
Sweat.
sweat,
Okay.
yeah, which is very also important. Really लेना चाहिए. You never know. Lower socioeconomics, they generally they touch their children and then
Yes.
so एक ये भी important. Salty to taste the sweat, which is very वो भी आप एक बार ले सकते हैं. Because sometimes you may not get a typical history of bulky stool. आपको पूछना पड़ेगा oil droplet तो नहीं आते हैं. Something like that.
Yes.
क्या
Yes.
कई बार oil आता ही नहीं है. कई बार होता ही नहीं है ये सब. And they feel that it's normal. But there is sometimes the noisy breathing in the child जो they are not able to understand because they can have the nasal block or something like that. तो noisy breathing में भी आपको पूछना चाहिए कि किस टाइप की गड्ढे पड़ते थे, छाती के ऊपर पड़ते थे या फिर वो supraclavicular पड़ते थे या कैसे पड़ते थे. You could have asked this question to them. मतलब
Okay.
just before seeing, so that will very well tell you कि it's an upper airway or it's a lower airway. So this way you can differentiate.
Yes, ma'am. Okay.
I think got my point. So these two
Yes.
things in history and examination, you can ask the parents about it.
Yes, ma'am.
Okay. Next. आप आगे बताइए.
So, now coming to the head to toe examination, the finding are as per examination, which was done on 22nd of the July. The head was normal in size and shape. The hair was again normal. The face, there were no signs of disformism. Mild frontal bossing was present. There was nasal flaring present with nasal prongs in situ. Lips again normal. Eyes, there was no pallor and icterus. Yes, again, there was no discharge noted in the external auditory meatus. Bilateral TM could not be assessed due to a partial earwag, so they could not be fully assessed. And nose and nasal cavity, there was normal. There were no polyps seen in the nasal cavity, and there was no paranasal sinus tenderness. And neck, there was no cervical lymphadenopathy. Abdomen was soft, non-tender. Skeletal system, the child was had a normal gait. He was able to walk comfortably, and there were no signs of clubbing ma'am, in the extremities, upper extremities.
Clubbing, अच्छा clubbing, okay, that is
Yes,
okay.
ma'am.
You can do it. Sensorium बताया आपने? Sensorium क्या था?
Sensorium, ma'am, the child was a little apprehensive, but he was fine. He was conscious, alert, and aware. He was following commands,
Following
but
commands.
he was apprehensive, little irritable. We can see.
Was he able to speak verbal?
Yes, ma'am. He was speaking
So
2
he
to 3
was
word
following your
sentences, ma'am.
commands.
Meaningful sentences, ma'am.
This is very important कि आपने neurologically भी ठीक से देख लिया है. Did you
Yes,
go
ma'am.
for a knee jerk or something like that? Did you do that? Right.
Ma'am,
आप जब
yes, I didn't see NS. Yes, ma'am. Knee jerks and the tone was also fine. There was no muscle
Fine.
wasting, and ma'am,
Hyperbolic,
nothing like
yeah.
that. Yes,
Hyperbolic. So you were able to see for the nasal polyp, very difficult to see, but
ma'am, I just looked at the nasal vestibule, like the enteroconal polyp can be seen, but ethmoids can't be seen in the nasal.
yeah.
Just,
So we don't rule out the things, but yes, you can say the nasal turbinates were normal, and you were not able to see visibly any a polyp or any mucosal thing jutting out. Very difficult to rule out polyp like that.
Yes,
And
ma'am.
here you have already told, well, very good that you have tried to do it and it was wax. ठीक है. So they were subcostal retraction or they were like supraclavicular. कैसे retractions हैं इनके बताएंगे
They were
दोबारा?
subcostal and intercostal retractions.
Okay. And what they were any audible wheeze or audible nut was sound from the chest? Did you hear something?
Yes, ma'am, I did hear. I will come to the respiratory examination also. But
Fine.
yes, ma'am, there was no the wheeze was audible on auscultation, not like without auscultation, it was not audible. Now coming to the
You are
systemic
coming to the
examination.
cardiovascular and the systemic, na? You're coming to respiratory
Yes,
and
ma'am,
systemic.
systemic examination, ma'am.
Right.
Now coming to the systemic examination, now I'll start from the respiratory system. On inspection, there was vertigo breathing was increased. The child had tachypnea with a respiratory rate of 44 per minute. There were visible chest retraction, intercostal retraction with nasal flaring. Now the shape and symmetry, there was no the shape of the chest was normal and the symmetry was also normal. And there was on inspection the chest was seen the expansion was equal on both sides and there was no obvious asymmetry noted. And the trachea seems to be in midline on inspection. Now again on palpation, the findings on inspiration was confirmed. The trachea was in midline and there was a symmetrical chest expansion. No like and the one more thing on inspection, the chest ma'am looked a little hyperinflated. So that I forgot to mention. Yeah, but yes, it was an inspection finding.
And
Now
sternum?
coming
Sternum was depressed or was it like
no chest, no stem impression.
fine? You have to rule out rickets in that, which is very
Yes,
thick.
no rachitic changes. Other than the frontal
No
bossing,
rachitic.
there were no rachitic changes, ma'am.
Right, because you said frontal bossing, that is why I was
Yes,
expecting some.
ma'am. No, ma'am, no rachitic rosary, no Harrison, nothing sort of that.
Right.
Now coming to the percussion, there was a hyperresonant note noted in the third to fifth intercostal space, and auscultation there was bilateral decrease air entry with and expiratory wheeze. It was a little more on the right side, but nothing, not a significant, not very significant. There was no crackles, there were no stridor, and there was no pleural rumble on auscultation.
Okay.
And one more thing, ma'am, expiration phase was a little prolonged, ma'am.
Did you feel that from? Okay.
From auscultation, ma'am.
Auscultated.
Yes, ma'am. Auscultation, I felt that
Was
expiration was a
the-
little prolonged.
the
It was
wheeze-
almost equal. Yes, ma'am.
Was the wheezing expiratory or inspiratory or by both?
Ma'am, I heard like expiratory, but yes, ma'am. As far as I heard, ma'am, it was expiratory.
Good. So expiratory wheeze goes in favor of what? Again?
A smaller airways, ma'am.
Small airway, yeah,
Involvement airways,
exactly. A
involvement.
small airway obstruction. And that small airway obstruction, we may be dealing with bad asthma, or we'll be dealing with this obliterated broncho boob we are talking about. So
Yes,
this rules out the larger airway or the upper airway involvement. And along with that, this wheeze was always there, or some crepitation you could
diffuse. Ma'am, no, ma'am,
diffuse
no crepitation, but the wheeze was diffuse in, I heard it in like all the areas, and there were no crackles, ma'am, no. nothing sort of
So
crackles.
it is very difficult in a child or in a baby
Yes,
in a
ma'am, they
2
can't have
months
deep
to
inspiration.
हाँ कि
Yes.
can't see कि लोबार है कहाँ है वो चारों तरफ ही आपको both the bilateral ही feel होगा but चल it's okay but you can expect a crepitation also in such cases maybe you have not auscultated during that time okay fine आप आगे चले
Yes, ma'am. Per abdomen examination, the child was examined in supine position. On inspection, the abdomen looked mild distended. The lip was palpable 2 centimeter below costal margin, and the umbilicus was central inverted. No scars, no visible peristalsis. And on palpation, just there was liver was palpable 2 centimeter below costal margin. Span was 9 centimeters. On percussion, the abdomen was tympanic, and normal bowel sounds were heard on auscultation.
okay.
Now coming to the cardiovascular examination and inspection, there were no signs of hyperdynamic pericardium. On palpation, the apex beat was palpable in the left side and there was no palpable pericardiac heave. On auscultation, I heard S1 and S2 and there was no murmur and no loud P2.
Perfect if there's a chronic lung disease though it
Yes,
is very early what do you feel it may be any what can you think of cardiac evaluation में क्या हो सकता है
ma'am, actually, any chronic lung pathology can lead to chronic hypoxemia, and which can lead to chronic pulmonary vasoconstriction, which will increase the pressure on the right ventricle. So there could be pulmonary hypertension, right ventricular hypertrophy, some sort of that.
yeah so loud P2 will be there or like what so
Yes,
signs
ma'am.
of pulmonary hypertension how do you see in such ladies
Pulmonary hypertension, if the child develops like ma'am, pulmonary hypertension, clinically the hypoxemia will worsen, ma'am.
नहीं अगर आपको palpate करना हो
Palpate. Ma'am, pericardiac heaves can be there, like in a right
paracardic
ventricle.
leak can be there and loud P2 can be there ठीक है otherwise
Clinically,
clinic
yes, most.
just 2 minutes okay we can go further
Yes. Now coming to the CNS, again the child is conscious, alert, and aware of the surrounding. There was no cranial syndrome, no focal neurological deficits. On the muscle, again there was no muscle wasting. DTS were also normal. Not mentioned, but yes, did so. I saw knee and ankle jerk. Those were also normal. The tone was also normal. There were no wasting on either side. The bilateral bulk was comparable and it was fine.
good yes okay.
Now I'll like to summarize on the basis of history and examination. 22 months old male, all developmental milestones seen normally. Immunized till 6 months of age, admitted in Sargangaram Hospital with complaints of fever, cough, and nausea breathing. 7 months back, followed by chronic persistent breathlessness and oxygen demand for 6 months. On examination, the child is pallor and mild frontal bossing with respiratory distress. There were hyperresonant lung fields with bilateral decreased air entry, wheezing on auscultation with normal cardiac examination and no signs of chronic hypoxia.
No signs of chronic hypoxia on history and examination, right?
Yes, ma'am. Just change.
Okay. So possible differential diagnosis.
Possible, ma'am. I have again
on
kept a
history
chronic
and-
lung disease, likely post-infectious bronchiolitis obliterans, but again, CF can be there.
Yes. And any other cystic fibrosis.
Cystic fibrosis, ma'am. Yes.
3 things you will think of. And fourth, you can say a very resistant asthma, but very difficult to say. But
test. So this
phenotype.
test. Yes, ma'am.
Yes. So how do we go further now? Should we are going for the pathology, Dr. Suresh? Are we going further for the diagnosis part or like or
Yes,
the
ma'am. We can go. Yes, ma'am. We
आपका
can.
तो कैसे टाइम अलाउ है कोर्स ड्यूरिंग द हॉस्पिटल स्टे आपने क्या किया वो इम्पोर्टेंट है आपको जो हॉस्पिटल में क्या किया
Yes.
हाउ डिड यू ट्रीट
Yes.
दिस चाइल्ड या
Yes, ma'am.
एनी
Now.
रेडियोग्राफिक इमेजिंग यू कैन शो इफ यू हैव इट
Yes. CT were ma'am done, but actually the images were not available. That,
एक्सरे
but
एनी
we
एक्सरे एनी एक्सरे
X-ray, ma'am. Actually, ma'am, the parents had come from IVIG infusion and they had forgot all the X-rays and
तो आपने
CTs.
अपने वहां नहीं कराया एक्सरे वहां
मैम
पे
हमने करवाया था. Actually, I forgot to add images.
नो
हमने
हाँ
करवाया
वेरी
था.
इंपॉर्टेंट
We
तो
have done HRCT, ma'am. HRCT was done.
हाँ पर पहले एक्सरे होना चाहिए ना तो चाहे
Yes, ma'am.
अपने यहाँ पे भी
X-ray is
हो रहा
first
हो
line.
एचआरसी
Yes, ma'am. First line is X-ray, ma'am.
First line is X-ray wherever you go into government or private or your own setup or whatever. First go for an X-ray. And then because if you see minutely those X-rays, you will so many times rule out many things and all that. So what do you think what can be the X-ray in this picture? You went to the CT again.
Ma'am,
But
on
what do you think?
X-ray, there could be hyperinflation, ma'am. They're finding signs of
There can be
hyperinflation on X-ray.
consolidation, and
Pneumonias, yes, ma'am. Air resolving or something persistent pneumonias, like something, there could be hyperinflation.
if you're
And
thinking of BOOP, then which lobes are involved more? Like
ma'am, if I'm thinking of,
BOOP, if you're thinking of obliterative
okay,
bronch, what do you think may be the most affected lobes in the lung? Well, most commonly affected. Is it a central part or is it a peripheral
peripheral,
or is
yes,
it
ma'am, it is
upper lobe?
usually peripheral.
Yeah. And
It's
in what
peripheral.
happens in cystic fibrosis? Is it central or peripheral? आप यहाँ पे आप थोड़ा सा could have read central bronchiectasis
Central,
mostly.
yes, ma'am.
Yes.
Central.
And in this peripheral. Fine. So
Yes.
थोड़ा सा वो आप X-ray में देख सकते हैं. Oh. And lower lobes are more involved in this bronchiolitis obliterans. And in the CF में ऐसा कुछ नहीं होता. Mostly upper lobe भी या कोई भी involvement होती है. एक.
Okay.
तीसरा आपने एस्पिरेशन की कोई हिस्ट्री ली थी बच्चे की?
Yes, ma'am. There was no choking of
feet.
feet, ma'am. No
More
sudden
important.
onset of dyspnea nahi tha, ma'am. There was no sudden onset of breathlessness.
What might be the other
And
causes
knees.
of BOOP? What are the causes of BOOP? Like infections? में क्या क्या आता है? What type of infection?
Like ma'am, there could be ma'am viral infections, ma'am, like
Yes,
in
viral
adenoviral.
and adenovirus. Very good.
Adenovirus,
Or
influenza virus can cause it, ma'am. Mycoplasma bacterial,
RSV,
RSV
yes,
can cause it. Parainfluenza can cause it. Varicella, something like this.
and mycoplasma.
Adenovirus, mycoplasma bacteria.
Yes,
Yes, ma'am.
mycoplasma. Very important. Okay. So this might be very important. Mycoplasma, this and that. So you should ask the history of boils and other rashes of the child. ये important. I think वो आपने पूछा है because of thinking कि virus can also cause rashes in the body also, boils also in the body, and along with the fever, which could have happened during that time. So mycoplasma, and अगर COVID चल रहा होता तो COVID भी करता. ठीक है?
Yes, ma'am. SARS-CoV-2 can also cause it. Yes.
SARS-CoV-2. So these are the few causes. Bacterial is less likely. So how did this child responded then? Did good antibacterial was given? Like what happened? Like
Yes, ma'am. Antibacterials were given like in. It was given in ICU, ma'am. The child, when we received the child, the child was in respiratory distress, and the child was received an emergency, and then a PICU admission was done. And some investigations, ma'am, revealed adenoviral pneumonia. It was diagnosed on respiratory biofire, ma'am. Then again,
अगर
the child
respiratory
was put
biofire नहीं होएगा आपके पास, अगर respiratory biofire नहीं है आप
adenoviral.
नहीं, अगर पेशेंट अफोर्ड ही नहीं कर सकता या नहीं कर
Yes,
पा रहे हो
ma'am.
तो क्या करोगे फिर? तो वो कुछ नहीं, आपको एडिनोवायरस वगैरह कैसे कर सकते हो आप?
Clinically,
क्लिनिकली
red
RSV
eye,
के लिए एट द मोस्ट थ्रोट स्वैब
red eyes,
भेजोगे, बट वो
throat
भी
swells.
मुश्किल ही है उसमें निकलना एंड ऑल दैट.
Yes,
सो
ma'am.
बायोफायर तो
Difficult
अब
to.
हुआ ना, पहले तो इट इज वेरी डिफिकल्ट. हाँ, अगर
Yes,
बट
ma'am.
स्टिल
Resource limitation.
बेसिक इन्वेस्टिगेशन ऑफ थ्रोट स्वैब शुड बी गिवन, दो इन दैट स्ट्रेप्टोकोकल वगैरह ही आएगा, बट वो and
Advanced in
biofire.
culture is.
If biofire is not there, then you have what do you expect in blood samples? Did the child went for any bronchoscopy or something? Like no.
Yes,
Was
ma'am.
it?
Bronchoscopy was done, ma'am.
And what was the result in bronchoscopy? बाल का क्या निकला था?
Ma'am, bowel में actually bacteria was there was bacteria. Ma'am, culture was sterile in bowel and lipid
नहीं,
laden
कोई
macrophages.
साइटोपैथोलॉजी होता है तो उसमें कौन से सेल्स निकलते हैं? लाइक माइकोप्लाज्मा में लिम्फोसाइटोसिस होता है.
Okay,
तो
okay.
क्या
It was
ऐसा कुछ था?
lymphocytic cell, lymphocytic
Yes,
predominance,
so
ma'am.
इसमें lymphocytosis predominance होगा, ठीक है, क्योंकि
Yes.
it is not a typical this thing. It can be there, and you can rule out by sending the culture that there is not a major bacterial infection.
Bacterial infection, ma'am.
और कोई हिस्टोपैथोलॉजी में और भी कुछ नजर आता है? लाइक हिस्टोपैथ में कुछ और देखते हैं क्या आप? बीडी का कुछ या फिर
Bronch,
HRCT
ma'am,
दिखा दीजिए
usually
अगर आपके पास है तो.
biopsy were actually, ma'am, actually
नहीं है, अच्छा
forgot
कोई
that
बात,
they
कोई
didn't
बात.
had films, ma'am. Sorry, I should have added, ma'am.
You should have
But they
added the
didn't
X-ray and the
have.
CT. What type of
CT.
CT में क्या होता है? कुछ typical पता है?
Ma'am, high resolution CT is done in such cases, ma'am, and
Yes.
it is
Why
there
not
is
CCT? Why not CCT?
ma'am, we want to see the airways and smaller airways and alveoli level, ma'am. So HRCT is better.
HRCT is better. But अगर आप tuberculosis सोच रहे हो तो, or in
CCT is
fact
the
cystic fibrosis, so CCT is better. Contrast.
CCT.
So very important. Yes. So because you have to look at the
CCT
lymph
is
nodes and all that. So this is HRCT, and Bal lavage is important, and anything you know about boot more, like what type of cri like
Like,
how
there are
do we
three
diagnose? What are the
types.
criteria to diagnose? That is important.
Usually, we divide it into three types. Like, first is
Right.
post-infectious. Second is, post-transplant,
Mm-hmm.
post bone marrow transplant, can be
Mm-hmm.
there. And usually it is diagnosed by both a good clinical history, good examination, and radiologically, and the final diagnosis is made by histopathology.
What do you see in histopathology?
Histopathology, we can see like there is obliteration of the smaller airways, bronchioles. There will be fibroblastic activation, and the bronchioles will be filled with like there is like fibroblast collagen deposition of them. There is obliteration of the smaller airways, so their lumen is very narrow, which causes the permanent like anatomical obliteration of the
Right.
bronchioles. Ma'am.
So वो कई बार बाल लवाज में नहीं आता और हिस्टोपैथोलॉजी में आता, पर हिस्टोपैथोलॉजी कैसे करोगे फिर? वो आपको टिश्यू वगैरह कुछ लेना पड़ेगा, तो वो लंग बायोप्सी के थ्रू ही
Histopathology,
होता
ma'am, it
है,
is
बट
an
नॉट इन
invasive
एवरी
procedure,
पेशेंट.
ma'am. Yes, ma'am.
हाँ,
Invasive
so
procedure,
may not
it,
be,
it
हाँ,
has its
but
complications, ma'am. Yeah. Yes. We
so
have to
how many
sedate the
percentage
child.
go for this? Yeah, very severe book में हम कई बार अगर I don't know if they recover or something then, but it is said. But somehow we diagnose by criteria of clinical,
Clinical,
radiological,
radiological.
and non-responsive to
We go for
bronchodilators
rest.
and good high-end antibiotics. This goes into the picture, and histopathology if possible. The BAL sometimes samples can also tell you about the associative findings. So how do you treat the child?
Yes, again, ma'am, since the child has developed the bronchiolitis obliterans, so now it is more of a like a conservative treatment only. Like we have to improve the quality of the life, and we need to like prevent and progression of the symptoms and respirate. So it is mostly conservative and supportive treatment, ma'am. There is no definite treatment which will reverse the pathology, ma'am, since uh,
What is the
it is
role
an
of steroids in this?
yes, ma'am. Initially, yes, ma'am. Initially, yes, ma'am. We can use steroids. Pulse dose of steroids is indicated in such conditions. At we can give steroids at 10 mg per kg for like 3 days, and we have to give like multiple doses monthly, ma'am.
10 to 30 milligram per kg.
10 to 30, yes, ma'am.
Per,
10 to 30 for each.
yes. देखो, most important drug which is good is prednisolone.
Yes,
If the child is having a mild variety, you can go to oral or IV. Oral prednisolone may not be pulse, but if it is little on the moderately severe, you go for pulse. For how many months? 2 to 3 pulses, 3 months की तो आपको
ma'am.
requirement होती है. Will the
Yes.
child start recovering immediately? Yes. There's a good response to steroid, which is
Yes,
very important. What is the prognosis of such children?
ma'am. Prognosis again depends on the initial presentation. Like, how was the child? Is it a milder form or is it a severe form? Does it require
It
mechanical
depends.
in? Yes, ma'am.
It depends when early the child is
Early
diagnosed.
treatment.
Yeah, that is important. If
Early
7 months have
interventions.
already passed and he has developed the irreversible changes, then even after giving the steroidal this thing, it is very difficult for you to get him back to the same position. But if the child is diagnosed early and you give start with the steroid treatment, maybe whatever the pulse or the oral or the daily, then the improvement is very good and it can revert it also back, which is very important. So early
Yes.
diagnosis is important in this children. So this is very
Yes,
important.
ma'am. Early
So
diagnosis,
the
early intervention.
cornerstone is steroid, but यही एक जगह है जहाँ पे steroid use करनी है और जगहों पे इतनी judicious rather नहीं use करना. तो ये point is very important to this thing.
Yes,
अगर
ma'am.
बड़ा बच्चा होता तो आप कैसे वो diagnose करते थोड़ा? इसमें pulmonary function test का क्या रोल है?
PFT, yes, ma'am. PFT can be done, ma'am. Yes, ma'am. In like older children, like 5-year-old, more than
हाँ,
5-year-old
इसमें क्या
children.
क्या क्या आएगा आपका?
Obstructive pattern will be there, ma'am, in PFT. Ma'am.
Will it respond to your bronchodilator test?
No,
Like
ma'am.
आपने
Usually,
PFT कराए होंगे लोगों को? हाँ.
yes,
Have you
ma'am.
done yourself PFT with BDR?
Bronchodilator challenge test, yes, ma'am, can be done, but there will be poor response in these children,
So
ma'am.
it will be a fixed airway obstruction.
Fixed airway obstruction, yes, ma'am.
Yes,
Fixed.
very important. If say your 5 or 6 year old child, you go for a PFT in that, वो कर तो लेगा obstructive, but when you give the bronchodilator in the form of levolin or salbutamol, inhalation therapy, like 400 microgram, 200 microgram, we give to via spacer and puff, the response will not be there. So this is very important to rule out it's an asthma or not.
Yes,
ठीक
ma'am.
है? अगर cystic
Response
fibrosis
to
होगा तो
bronchodilators.
उसमें क्या होगा? उसमें obstructive और restrictive दोनों हो सकता है. Again, it will poor response to the bronchodilators.
Okay.
This rule is very
Yes, ma'am.
important.
Yes.
Anything else, Dr. Suresh? I think whatever the time demands, I think if you have in your mind, you can ask us, Dr. Shubham. Very well
Ma'am, can we-
presented.
Thank you.
हाँ, CT आपका आ गया है. CT में आपको क्या नजर आ रहा है?
Ma'am, like there is ma'am mosaic attenuation, ma'am, in PIBO. Usually an expiratory HRCT is more sensitive than an inspiratory HRCT, ma'am.
Yeah.
So there will be fixed airway obstruction in
पर ये ना छोटे में एक्सपिरेशन इंस्पिरेशन करना बहुत मुश्किल है 22
छोटे
months
बच्चों में,
पे.
ma'am, it is
और
not
दूसरा
possible.
अगर आप
Child will be, yes.
अगर so be good. So
Okay.
if a child allow better results. एक और भी साइड होता है सीटी में इनवर्स, वो पढ़ लेना क्या होता है सीटी में. वो ब्रोंकाइटिस प्रॉब्लम की एक पार्ट है.
Yes.
right है ना इनवर्स.
Yes,
one
ma'am.
more these
Sir, actually, sir, you are muted, sir. Sir, actually, you're muted. You're not audible, sir.
now. Hello.
Yes, ma'am. Am I audible?
Yeah, I think there's a connection error. Dr. Fish is there.
Yes, ma'am. Actually, sir's mic was muted, I
Installed.
think.
दूध जैसे उसके बाद मुझे दिन में फिर बाद 2-3 बार दूध दे दूं. दूध की क्वांटिटी हो रही क्योंकि अभी कम है.
Any
जैसे
question
पहले
from the author
अच्छा एक
from
चीज सॉरी
the
एक चीज और
participant?
जैसे भी रात को सो जाता है 12-1 बजे.
Shubham, can you hear me?
Yes, ma'am. I can hear. Yes.
Any, you can just, I don't know if I can see the chat. If any questions somebody has, we can be answer that.
See, ma'am. I can't see any questions on chat box, ma'am.
Yeah, even I can't see any question. I would like Dr. Suresh. Can we see you? Can we talk to you, Dr. Suresh? Can anybody call in?
I'm online. Yes.
Yeah, hi, Dr. Suresh. Yeah, sir, we have discussed the whole case, and if there are
I
any
know.
questions from the other participants, they can
think
There
ask
is one
us,
question,
or
ma'am.
we can whatever you say.
I
There
can't
is
see
one
any
question,
question.
ma'am.
Yeah,
Let me see.
yeah. Tell me the
There is
question.
There is one question, ma'am. How do we suspect adenovirus RSV infection clinically?
Hello.
Yes, sir. Sir, you're audible, sir.
Dr. Smith there. Dr. Jasmeet there. She's answering.
I think, ma'am, the ma'am's mic is muted, I think.
डॉक्टर जसमीत आपका माइक ना म्यूट हो गया है. Anyway, in clinically you cannot make out which virus it is. whether this is adenovirus or RSV virus or influenza or parainfluenza. Only by doing viral studies you can say. And with some viruses, it's more likely that they may develop obliterative bronchiolitis, and other viruses are less likely to cause this thing.
Yes.
All viruses have the propensity to lead to this kind of this thing. Right? Boop.
Yes, sir.
Can you hear? Just
Yes, sir. You're audible, sir.
नहीं, जब जसमीत का माइक म्यूट है एक्चुअली उसका
Yes, sir. Actually, sorted.
तो उसको उनको मैसेज डालें क्या? तो डाला नहीं, वो बोल रही हैं पर उनका माइक, उनका लगता है स्पीकर भी शायद
Yes,
off.
ma'am. I think
I
there's
think.
कोई issue, there's something issues.
So anyway, any more questions are there? I can't see any questions in the chat
No,
box.
sir. There is no, sir. Actually, they are in question and Q&A box, sir. But there is only one question, sir, that we have answered.
Okay. Dr. Jasmeet,
Yes, yes.
somebody has asked, how do you know clinically is adenoviral infection?
Yeah, can you hear me? Can you hear me?
Yes, yes.
Yes, ma'am. Yes, ma'am.
It's all the viral infection have the same illness, like it's like fever, cold, URI, bad rhinorrhea, and all that stuff. So very difficult to say it is RSV or adeno until the respiratory season is going on. So that is the only thing. So I think sir is right about Dr. Suresh that you need to test. It is very difficult to diagnose it clinically. So all viral symptoms are almost the same. Like you can have rash and adeno. It's almost the same. Only the respiratory time is important during which time you're having this illness. So I think that may be the part. Can you hear me?
Yes,
Hello?
ma'am. Yes, ma'am. You're audible.
If there are no
So
more
loss
questions,
of signal a
can we-
little, I think. But,
can we close
yes,
the
sir.
session?
yeah.
Yes, sir.
Yes, yes.
No more
Yes.
questions, sir.
Thank you, Dr.
Sir.
Jasmeet and Dr. Shubham for
Thank you, sir.
this webinar. And I think it was very, very useful
Yeah.
and a very good case. And more than that, a very good discussion by Dr. Jasmeet. Right. Thank you, Dr. Jasmeet, once again for joining us.
Thank you, sir.
On the platform.
Thanks for being, yeah. Yeah. Very
Good night.
nice.
Enjoy
Thank you very
yourself.
much all. Thank you. Good night.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Good night.
Okay.